Good evening, students, ladies and gentlemen. I'm delighted to present to you our Professor of Medicine, Prof Dedousis, who's kindly agreed to give a couple of talks on two very important topics, which you will be encountering very regularly in general medicine. The first talk tonight is on assessment and management of delirium and dementia. Many of the students amongst you have been privileged to work with Dr. Dedousis, and I'm sure many will be keen to see him and meet him and work with him and get the privilege of learning from him over the next few years. I'll leave the podium with Professor Prof Dedousis to speak with you about delirium and dementia. Thank you, Chris.
Okay. Good evening, everyone. I've met some of you I have not met and hope to meet very soon as you go through the medical component of the course, working with us both at St. George and at Carina Private. It's a little bit different talking like this over the internet, me being an old dog, trying to learn new tricks, but it's the way of the world. Today we're going to talk about two things. I'm going to be a little bit naughty and stretch the time a little bit to over an hour, and I hope you don't mind, because these are two of the areas in medicine you need to be aware so as to be able to manage things fairly easily. Those of you who have done medicine would notice that the majority of our patients are elderly. There's hardly any young guys. The issue of delirium and dementia comes up again and again and again. And I want you now at your stage, and I don't know what stage you're at, whether you're third years or final years, to be comfortable with managing, assessing, and when you hit your internships, my aim is to have you prepared to be able to be an effective team member and deal with the issues. Let's go on to delirium. Yeah, what a change. Okay, so delirium, the simple definition, it's an acute confusional state, guys. Concentrate on the fact that it's acute. It happens quickly. It comes quickly and it goes away relatively quickly. It doesn't hang around for a long time, okay? The course happens overnight. You can have one afternoon walk around with the patient's fairly fine, and then you get a phone call by midnight, patient's confused. The change is usually over hours. Is in mental status. They're very, very disorientated. They're confused. They have problems with recognizing, talking, communicating, aggression, behavioral problems. It fluctuates. It's usually worse at night and better in the morning. Doesn't usually last more than a month, guys. And if it goes for longer, you can have subacute periods of delirium, but usually it's self-limiting, and within a few weeks, it's gone. Certainly less than 6 months. Now, we see a lot of it. I need you guys to be aware of it. I need you guys to be able to recognize it and be able to manage it. Because let me guarantee you, when you become interns in our system, and wherever you practice, it may be a country hospital, it may be a city hospital, you will see a lot of it, and you need to be prepared to manage it. Often you won't be able to reach out and get help from a registrar or resident. You may be on your own, and therefore you need to be comfortable with dealing with it. Anything between 10 to 30% of hospital patients with medical illnesses may have a delirium. When you work in the surgical wards, almost 50% of them, especially those with high risks, are going to be delirious. The post-surgical patients are often very delirious. It doesn't matter if they've come in to have their toenail removed, or as in Professor Garrity's case, have surgery to their spine. A lot of them end up getting quite confused in the post-operative period. And guess who's left there dealing with the patient? The intern. And that's going to be you, my friends. So I need you to be able to recognize and manage. Now, early identification is important, because people say to me, well, so what? What's the big deal about delirium? Why do we care? Why is it important? Well, the brutal fact is delirium brings on other terrible things. There's problems with mortality and morbidity that you get with delirium. You get increasing cases of ischemic heart disease and sepsis, whether it be pneumonia, increasing cases of pulmonary embolus associated with delirium. You get more physical injuries. They hurt themselves. So the patient who's on the orthopedic ward, guys, who's coming to have his broken noff fixed, falls over because he's delirious post-operatively and breaks the other noff. I'm not joking. Happens all the time. We deal with it. They injure their heads. They injure their arms. They have a subdural after falling and hitting their head after their surgery to their knee. So you've got to be aware of the things that happen because of the presence of delirium. It causes an increasing length of stay. Now, I must admit, length of stay has never been my big issue in the world, but in reality, in the 21st century, we must all be very mindful of the limited availability of resources and the way that we have to cycle through our beds. And it does cause prolonged stay of patients in hospital. And I find it more important because a prolonged stay means the patient's exposed over a prolonged period to other issues that could go wrong with him. There's an increased rate of institutionalization. What do I mean by that? It means nursing home. Delirium, severe cases of delirium, issues associated with this can end up causing the patients to enter a nursing home. And I tell my students and I tell my residents and interns, one of the most, I suppose, depressing part of my week is going into the nursing home because they're not pleasant places, guys. And I'm not sure how many of you have done nursing home placements, but, you know, I don't want to be in one of those, that's for sure. It's certainly something that you should think about, and it should sort of press your button. It should turn the little red blood in the back of your mind on, because it means the person has a reduced neuronal reserve. It means the person may have pre-existing cognitive decline, and this is simply just giving you an idea, hey, this is unmasked that the fact that they're delirious means something's cooking. You know, I saw a lady today in our rooms who had 2 episodes of delirium, and the intern referred the lady to our clinic because, hey, there's 2 episodes of delirium. This little red light went on in this intern's head. Here we are in the office, and this lady has a dementia clear cut. It's easy to see. So you pick it up. It'll, you know, obviously it prompts you to make sure that later on as an intern, you'll work out, review and follow up for the patient. So remember, it's not just confusion. There's a lot of things that can happen with a delirious patient, and they're not very nice things. So some simple diagnostic guidelines that you can use, and I've tried to put them A, B, C, D, E, which is easy. The impairment of consciousness and attention, the global disturbance of cognition, psychomotor changes that occur, the sleep-wake cycle, and emotional disturbances. And we'll go through them one by one. The impairment of consciousness, as these patients, their level of consciousness can vary. They can be a bit sleepy. They can be a bit tired. They can be in a coma, you guys. You know, when patients become delirious, some of them, they don't call out. They don't jump and kick and scream and jump out the window. What they do is they sit in the corner and they go to bed. They go to sleep. They're sleeping all day and unfortunately partying all night with their confusion. Always be suspicious of the little person, the little old man, the little old lady who's coming with sepsis or coming with whatever problem, and all they're doing is snoozing every afternoon and all day. Something's cooking. They can't focus, these people. They can't maintain attention. They can't sit with you and have a conversation. And you've got to be able to tell the difference between the dementia and the delirium. A dementia patient will sit there, he will focus, look you in the eye. He thinks it's 1928, but that's beside the point. He's focusing and sustaining attention, where these people are agitated, unstable, moving around, eyes are shifting, playing with things, unable to settle down, okay? You can try and do little tests like serial sevens, mini mental scores, or mockers. I'm not sure they're very beneficial, but you've got to look at their ability to focus and talk to you. Now, cognition, obviously goes off, but unfortunately there's situations where it goes right off. And we're talking about situations such as patients who become delusional, hallucinations, both visual and auditory, people in the corner, animals climbing the wall, spiders in the corner of the room, people outside looking through windows, making them very paranoid, very uncertain. From a cognitive perspective, their memory is poor, their confusion is obvious, their thinking is limited, their comprehension is very limited. They really go off. They can't do things, they can't sit there and tell you what you talked about 2 seconds ago, let alone 10 minutes ago. But you can see their cognition certainly deteriorates obviously and quickly. Psychomotor disturbances is important because sometimes we get a hypoactive delirium. So the patients will turn up in an emergency and you'll be the intern, or you'll be the medical student for that matter, being involved in the case, and the people are fast asleep, difficult to rouse, drowsy, sometimes almost unconscious, or they can be hyperactive. They can be jumping out of the bed, jumping out of the ambulance, jumping out of the window, running around DD, calling out. You'd be surprised at the strength and stamina that an 88-year-old who's delirious can muster as they jump around from emergency bed to emergency bed. And it's hard to visualize and picture, but you'll believe it when you see it at some stage through your careers. Their speech can be impaired. They can have difficulty in getting it out easily. Their reaction time is impaired, and they have a very significant startle reaction. So if you walk in and they'll clap your hand, or in my case, simply speak loud like I always do, you'll watch them jump. Now, it's very important to note the importance of the sleep-wake cycle in these delirious patients. What happens is most of the day, these patients will continue to sleep carefully, quietly, slowly dozing away. The nurses love it because, you know, they come in, they do their pill rounds, they do their observations. These patients have no disturbance whatsoever, so the day shift has an easy time. They look after the patient. The patient's great, they hand over. The night or evening start come along, and suddenly the patient wakes up, is confused, disorientated, and the party starts all night. And the nurse picks up the phone and says, "Come and sort it out, doctor, it's your problem." So we see these symptoms worsening at night. Sometimes they can be dreams and nightmares, but in many cases, they just don't sleep. They're up and wandering, seeing things, hearing things, and being very fearful and paranoid. It can be very confronting when you see it. It can be scary as an intern when you first notice it. You know, I'll take you back to 1990, I think it was. One of my first, I think it was an RMO, one or an intern, whatever I was, at Concord Hospital. And I was really proud of myself because I could do a lot of overtime, and I thought I was very experienced as an overtime working intern. And then they rang me from the ward to come and see a patient. And I knew I was in trouble, you guys, because as I entered the atrium, I could hear the screaming. And by the time I got to the room, 120 was the ward, which is the general geriatric ward. And there was the patient with 4 security guards holding him down. Yet it was the same patient I'd seen that morning who was right as rain, happy, a little bit drowsy and tired, and speaking very nicely and politely to me. So these things tend to be, you know, burned into your temporal lobe when you go through them. So be aware of the importance of trying to remember the reversal of the sleep-wake cycle and try to deal with it. Emotional disturbances. You will see these patients exhibit multiple different emotions. They'll be depressed, they'll be anxious and fearful, they'll be down and teary, emotionally labile, they'll be euphoric, they'll be quite apathetic. They can be all of the above, all mixed in one. And it's very hard for you to work out, is this a delirium? Is this a dementia? Or is this, what's the third D of aged care? Depression. Is this apathy and emotional lability part of depression? Sometimes it's very hard to tell the three apart. Anyone who tells you that they can do it easily, without any problems, I must say, my friends, I'm not sure how smart they are, but they shouldn't show off like that, because the best of us can't pick it sometimes, and we make mistakes, we make errors. I remember as a junior specialist many years ago, 25 years ago, I had a patient who I thought was a delirious patient, part of Lewy body dementia. And I warned the family about how bad he was, and I'll need a nursing home, and his poor prognosis. And then I walked in one morning and realized, when I assessed him and I found him trying to strangle himself, and he told me he shouldn't be around because he's a burden on the world, I realized I missed depression. So all his apathy and all his depression and all his emotional liability and all his confusion had been part of psychotic depression. He had 6 ECT courses and walked out. Professor Gonski has a picture of him walking out of the ward and never came back. So you've got to keep an open mind and, again, think of the 3 Ds of aged care. So dementia, depression, or other psychiatric disorders. Let me put you at ease with the last one immediately. The risk and the presentation of late onset schizophrenia, schizoaffective disorders, bipolar and all that, very rare. I've seen a couple in my career over 20 years, very rare. So you're usually thinking, is this a delirium? Is this a dementia or a depression? And you've got to work out what you think is going on and move forward, okay? Now, causes. What causes this? Now, this, my friends, as you see on the computer, is an abbreviated list. It's a short list, because to be perfectly honest with you, in an elderly patient especially, anything can cause a delirium. The simple movement of a 92-year-old from their home into a hospital to be admitted by you as the intern to have their second digit of their right foot straightened because of a pressure injury will result in a delirium, especially if they have underlying cognitive impairment. So you as an intern, you as a doctor, you as a medical student working on our wards here in medicine, need to go through a little list in your head to look for things. You don't need to remember everything, but look for common things. Look for drug issues. Is he toxic with too much DIG or tricyclics? You see how I hate tricyclics on my ward rounds and I try and stop them. Is he on too much of this medication, too much benzo? Is he having a withdrawal from alcohol or benzos? Many years ago, back in 2008, I think it was, we had a rash of deliriums on our ward in a public hospital, and we couldn't work out as consultants what the hell was going on. We had a closer look at things, and we realized one of our very well-meaning interns, knowing that benzodiazepines are not good for elderly people, stopped all the benzos. And as a result, all our patients were withdrawing and having a delirium. So think about medications and what medications they're on. Move on to metabolic factors, electrolyte disturbances, potassiums, calciums, renal failure, hyperglycemia, hepatic failure, let alone the post-operative effects of the anesthetic itself. Go to your endocrine causes with sugars and thyroids, and look at things like that. The nutritional deficiencies, less commonly seen, but still seen to cause a severe delirium at times. The most common cause will be sepsis, sepsis, sepsis. 1, 2, 3. Any type and anywhere. Look for pneumonia. Look for post-operative atelectasis with early pneumonia. Look for the UTI, the famous UTI. Look for cellulitis. Look for infected cellulitic fungal areas, tinea cruris, for instance. Move on forward and look at hypoxia, a person with COPD or CCF or pneumonia, or post-operative atelectasis from their surgery. For those who can hear the hoovering in the background, I do apologise. We may try in the bill and ask them to leave us alone. Next, does the patient have a stroke or a subdural? That's why the CTs are important. Have they had an injury, a head injury? Are they epileptic and they've had seizures that you haven't noticed, haven't recognised, haven't looked for? And do they have other intracranial problems? Again, guys, these are a small list of numerous things. And you as the medical student or the intern on the ward must be ready to jump. must be ready to look at these things, to go through them in your mind, one by one. Because as I said, you may not have the support of a senior with you at that stage, and you need to be aware of all these possible causes and work your way through them. Remember that, I said, Dedousis said, sepsis, so keep that foremost in your mind and look for it. Remember I said medication, so go through the medication list, look at it, assess it, balance it, make sure they're on what they're supposed to be, maybe not too much. Again, it'll fall into your hands to do this many a time. So, risk factors. Being able to recognize the patients that you see who are at risk of a delirium. I saw a man today in the office this afternoon, a lovely bloke, he's 87. He has a hole in his head. His skull is evident. That's because they took away a skin lesion, and he's had this hole on the head for a while. The family have managed it, but unfortunately, another skin lesion has presented itself. Forgive me, you guys. So the surgeon, well-meaning, wants to go in there and do a wonderful procedure where he removes the skin lesion, does a multi-layered flap graft requiring 3 operations. Now, you already, as the doctor involved in this case, know that he has some risk factors. The poor man's of advanced age, risk factor number 1. He already has pre-existing cognitive impairment, that's factor number 2. And the poor bloke also has a history of CCF and pneumonias. So you know, as the doctor in charge, when you're the intern and you have to clerk a patient or admit a patient, they're on your ward, you're the intern admitting, you have a look at them, you realize, okay, well, this guy's got at least 2 or 3 risk factors. He's got a high chance of delirium. I better be on my toes. I better watch out. I better look out and see how he goes. Other risk factors, depression, people with psychiatric illnesses, people with alcoholism, people who have too much ETOH or too much substance abuse, substance dependence. People who have a low albumin, serum albumin, tend to not do too well generally. Not only are they at risk of increasing delirium, but they're also at risk of not doing too well, both from the sepsis perspective and surgical perspective. And of course, an increased white cell count automatically either brings your eyes to the thought of sepsis, or it brings your eyes to the thought of, does this man have an underlying hematological problem / malignancy? So I'm relying on you as the senior medical students or the interns. When you're looking at these patients, you look at them carefully, you think about what you're doing, and try and be counterintuitive. Try and be ready for what's coming your way, because you know you've picked 1, 2, or 3 risk factors, and it's something to look out for as a doctor in charge. Now, of course, patients who are delirious will have to be investigated. What sort of investigations? Well, all the usual stuff that you're used to: pathology, drug levels, TIG levels, epilim levels, dilantin levels, ABGs, urine examinations and ECGs, chest X-ray and CTs. Now, these are all, common tests we do. It's not rocket science, you guys. However, all I ask you to do is to be very, very sensible about the timing of these tests. There's a time and a place for everything. Sometimes you're able to do all these tests easily, straightforwardly, without a problem. Sometimes you're a little bit of a gung-ho cowboy like I was. I'll give you an example. As an intern, geriatric ward, Saturday night, overtime during a thunderstorm. I was called in by the nurses. This little old lady was very delirious, and I decided I was going to investigate everything. Part of my investigations was the fact that I was going to do an arterial blood gas. I said to the 2 nurses, let's go, sister, away we go. I got out my, I think it was 23 gauge blue needle and my syringe. And the girls and nurses got the lady's wrist and held her down. And just as I was about to put the needle into her wrist, there was lightning, then followed by a clap of thunder. The lights went out. You wouldn't believe it, but it happened the way I'm talking about it. And the needle did not end up in her wrist. It went through my thumb into the nurse's hand. Let me reassure you, there was a lot of screaming and the nurses were not very happy with me, and obviously it was the wrong tested to at the wrong time, which of course I learned my lesson. And I was filling out forms in medical administration for a month after that, after getting a very severe talking to. So you've got to be careful. Some of these delirious patients, folks, you're not going to be able to put them through a CT of their head. You're not going to be able to put them or get an ECG or get a chest X-ray because they're too unsettled, they're too unwell, they're too delirious. So you've got to tailor your examinations and your investigations to what you can get done in a very logical and reasonable manner. Now, I will leave that. Environmental support. The nursing staff, the allied health staff, but the nursing staff are very, very important in helping you manage these delirious patients. You've got to try and keep the patient orientated to day and time. Talk to the patient. Now, you realize as the intern, you may spend, I don't know, 10 or 15 minutes with the patient before you have to see your other 22 patients. Where the nurses spend half their day with these patients. They have, I don't know, 4 or 6, at worst 8 to look after. So they'll spend quite a bit of time. So you and the nursing staff need to work together in a team approach. And that's one of the things I try and teach you in medicine here at St. George and Carina, is the work is that of teamwork. We work together. So it's important you tell the nurses and you yourself, keep the patient oriented, speak to them. Tell them it's Monday, tell them it's an afternoon, or tell them it's morning. Try and avoid that sleep reversal, that sleep pattern that's reversed, because it makes things, really difficult to manage. If it's morning, well, open up the blinds, open the light, let the sun in, wake them up. Don't leave them sleepy and sleeping under the cover all day because it's nice and quiet. If it's night, dim the lights. Make sure it's night. Turn the lights off. When the lights go off, your melatonin's released and everything's ready to go to sleep. Keep them to the time of day that they're in. Don't let them sleep because it's easy. Obviously, you want to be in the ward where we don't have too much sensory input, too much noise, too much calling out, too many people coming and going. Now, that's very difficult to achieve in many of our hospitals. Some do it better than others, but keeping them in a quieter area helps settle their agitation. And we know that's successful because, for instance, at Sutherland Hospital, and you guys won't have the opportunity to see this, but at Sutherland Hospital, you'll see that we have a specific area, or what we call an extension, where it's closed, it's quiet, there's only 6 or 8 people, everything's very calm, not too much noise, not too much running around, and people settle down quite quickly. We try and keep them to a single room close to where people can see them. We avoid lying in bed all day, which I've mentioned, and we try and mobilise them. We get the physios involved and only allow them a nap at lunchtime. Again, this is not rocket science, guys. It may look simple. Sometimes it's hard to achieve. Sometimes the nurse looks at you and says, "You've got to be kidding me. You want me to do what?" But you've got to try and give it a go. Sometimes it works in some patients and sometimes it won't. But you need to realize that these sort of non-pharmacological approaches are very helpful in managing these patients. Conservative and careful nursing is often all that is needed, okay? I can't again emphasize enough the importance of working with your nursing staff together to manage the delirium. It's very important. I'm not sure if you've learned it so far, but in medicine, we work as a team and our nurses are very, very experienced, some of them, and working together, you can get things sorted out. Now, I'm going to talk about a case of severe agitation, severe delirium, which I'm sure at some stage in your career you will come across. These aren't the simple ones who are sleeping in the corner or who don't know what day it is. These are the patients that are very, very agitated and aggressive. Patients that are a danger to themselves and a danger to others. I'll give you another example. Back when I was a young intern, I think midway through the year, again, I was a very confident big fella, and I thought I'd done a lot of overtime, and up I went and did a weekend, a 24-hour shift. And that was rare in those days to be allowed to do a 24-hour shift. It was a statement of belief in your abilities, and I was proud and loud. Anyway, I was Saturday, Sunday morning at 3 a.m. I got the phone call from that dreaded Ward 120. Please come help, quick, come and help. So I came in, ran up, and there was the first room on the left. And there I see, I think he was a Korean War veteran, because Concord was a veterans hospital, screaming at the top of his voice. And I could hear him screaming from the lift well, so I knew again that I was in trouble. There was 4 security guards, 1 on each limb, and 2 nurses in the corner, one with blood coming out of the corner of her mouth, having been struck by this gentleman, the other one trying to protect her and holding her head in her chest. She looks up at me and says, help, help, help us. He just smashed her. He just smashed her. So this is a situation where you may come across a patient who's very delirious, who's just hit one of your nurses or hit one of your doctors or hit one of your patients for that fact, and you've got to get stuck into it. Security is very important in these matters, and don't hesitate to call them. They are trained to help and deal with these delirious patients. Let me tell you, they're better trained than some of our police, keeping in mind the recent news articles you've all read, I'm sure. Restraints. Now, I'm pretty certain if you walked around the medical wards, both in the public and private system, and you said, sister, where are the restraints? No one can tell you where they are because we don't use them anymore. Restraints' general use has now fallen away. We know patients do worse with them. They get more agitated. They get worse. And thus, I haven't seen a restraint used for many, many years. However, it's in a case such as this that you would use some restraints as soon as you can get hold of them. But that's going to be a challenge because I'm not sure we even have any anymore. You've then got to diffuse the situation pharmacologically. You do have the patient held down by the security staff trying to keep him safe for himself and from others. What are you going to use? The use of benzodiazepines, though you want to avoid, you sometimes have to use. And you'll use something like clonazepam intramuscularly, 0.5 to 1 milligrams to try and calm them down. At the same time, using an antipsychotic, such as either risperidone or olanzapine, but you can't get in those in parenterally, so you'll have to use haloperidol. Now, haloperidol doesn't do much as far as sedation is concerned, but it certainly helps some of the taking the edge off the agitation and delirium, and together with the benzodiazepine should settle the patient. If you haven't got clonazepam, you can use midazolam. Midazolam has a short half-life of about 20 minutes. You don't want to get too many of those doses in a row because it makes their agitation worse sometimes. But you've got to get something in there to settle them down. Once you've settled them down, once you've made them safe, you may have restrained them and made them sleepy, then you can start looking at your causes, going through the list that we've talked about before, going through some of the investigations that you can do, some of them you can't, of course, and trying to work out what is going on. Again, as medical students or interns in this matter, don't forget that you look and ask for help as well. You'll be uncertain, you'll be scared, you'll be unsure. Do the basics that you've learned about today, that you've learned on the wards, that you'll learn in your medical exposure, in your medical terms, and always look for help. Ring the registrar, ring whoever's around, ring the consultant on duty, because we're always available to be spoken to. So that's a severe case, that's rare, but unfortunately, guys, it does happen. It is seen, and some of you will have to deal with it. Now, that's all I'm going to say about delirium. The reason I bring it up as a topic is I want you guys to be aware of it. I want you to be prepared for the simple fact that it's something that you will see as soon as you start your working lives as doctors. Hospitals are full of elderly people, and elderly people become delirious, and you'll be the first person on deck. You'll be at the coalface trying to deal with it. And if you could just be a little bit aware of the causes, some of the risks, trying to pick the patient that's going to go off and how you're going to approach them, I think it'll be helpful in your working lives and also beneficial for the patients. Now, what I'd like to do next is to quickly move on to dementia. I want to talk about dementia because I think it's important we really touch on it. It is just very common, you guys, and you see it. The average age of patients in hospitals now is in between mid 70s to early 80s, okay? The prevalence of dementia is very, very high. And again, you as medical students and as interns need to be aware of it, need to be aware of the types and the general principles in managing and what to look for. You don't have to be experts. You know, we spend whole careers dealing with dementia and dealing with the patients, but I want you to be confident enough to be able to recognize and deal with its patients. I put these two people up because, especially this bloke, dementia is not a normal thing. Dementia is not normal. It's not just grandmother who's going senile. It's a pathological condition that's seen in the elderly. The more elderly you get, the more likely you get, and you've got to be prepared for it. There are normal people. The first two people were jumping up and down in their late 80s, and they're having fun. They're not demented, and they're 88 and 89. One of them may fall over and break a hip, but for the time being, they're not demented. This guy here is obviously probably in his 70s. He's got married for the 5th time, and he's going to have some fun tonight. Again, he's not demented, and he's living a full life. Dementia, unfortunately, is a pathological disease of the elderly that gets more prevalent as time goes on. There are cognitive deficits that we see commonly: memory dysfunction, new learning, early learning, new information. They have issues with aphasia, apraxia, agnosia, executive dysfunction, but they also have functional problems, okay? They also have functional problems that go with the memory problems. It's not just memory, and you've got to remember that. Now, types of dementias. This is an older talk, so I would tend to agree that Alzheimer's is the most common one, usually about 50% of cases. First described in 1906 by Aloysius Alzheimer, who had, I think it was a series of 6 cases. These people were younger people, they were in their 40s. Progressive cognitive decline. Second most common is a vascular dementia. More so nowadays, and again, I'm sorry, this is an older talk, but I thought I had the opportunity, so I'd move forward. Vascular or mixed dementias bring a second, sort of the second horse in the race. And then thirdly, you have dementias, especially Lewy body Parkinson's disease, that cause dementia as well. But the most common one you'll see is Alzheimer's. I'll talk very quickly about mild cognitive impairment. It is a state, what we think is a state between aging and dementia. This is when people, and you won't see many of these people, guys. I will see them, but you won't. Because these people come to my office, they're about 76. They walk, talk, eat, drink, do everything perfectly well. They work, make money, go sailing, they play tennis, but they forget. They lose their keys. They forget what their wife told them to buy at the shop. Their short-term memory tends to be less than. Otherwise, everyone seems to be coping well. They're intact as far as ADLs is concerned. And they're, able to do everything perfectly, but they're forgetful. Now, we know that 1 out of 3 of these patients over 3 years will continue in this way, forgetful but very functional. But 2 out of the 3 of these patients over 3 will then move into a state of diagnosed full-blown dementia. And it just gives me an idea, hey, there's a problem here. Hey, I've got to have a look at this patient. And hey, I've got to work him up from all the vascular perspective, etc., to make sure I'm ready, okay? Now, we'll talk about Alzheimer's dementia predominantly. This is a graph I like to show you all so you understand where you're at as far as the cases that are coming your way. When I first started practicing over here, right, there was a lot of cases coming through. And look at that red bit, this whole red bit here, which is people over 85. Because you know what? People over 85 are living longer and longer because of the wonderful work by all the cardiologists with their antihypertensives and their aspirins and their antilipids and all that. They're living longer and longer. And as we get older, by the time we reach 90, 50% of patients have dementia. So now we're in 2023. Look at this tsunami wave of dementia cases. When I was a young medical student at St. George Public Hospital, for instance, there was one geriatrician in the 80s. Let me guarantee you that. At the moment at St. George Public Hospital, we have 18. At Sutherland Hospital, there used to be, I think, one geriatrician as well. Now we're currently sitting on 12. Therefore, between the two areas in the southern area of Sydney, we're sitting on 30 geriatricians just in the two public hospitals, just to deal with this wave of cases, as you can see. Etiology. I'll go quick. Age. Age is the biggest factor. The longer you live, the more likely you're going to get it. By the time you're 90, 50% will have dementia. Genetics. It's very important to be aware of the genetics. First of all, we have some very, very unlucky people who have a family history of genetic dementia, which is very, very sad. It's early onset. They have the presenilin genes 14-1, who knows gene 21 or down, I don't know how to go back, and they cause problems with dementia. Trisomy 21, remember, is the Downs patients. 99.95% will develop dementia. But even if you don't have those gene issues, even if you have a first-degree relative, a mum or a dad or a sister, your chances are significantly elevated into the 20 and 30% chance. And then the vascular risk factors become and play an issue. So if you have a parent who got it early at the age of 58, and you as a son or a daughter are a smoker, drinker, obese, hypertensive, diabetic, couch potato, then your chances, my friends, are very, very bad. But if you have a mum or dad who got it at 91, and you're a fit person who jogs and doesn't smoke and doesn't eat and doesn't drink and is very healthy, then your risks tend to decrease down to less than 10%. Now, the neuropathology of Alzheimer's dementia, it's all about plaques, tangles, and neurotransmitter losses, okay? So what's that? Sorry. So plaques are caused by the deposition of beta amyloid protein. It's a byproduct that's unfortunately created when the cholesterol sort of protein is metabolized by one of the secretases, usually alpha secretases, cut the molecule and the body is able to metabolize. But unfortunately, in Alzheimer's dementia, beta and gamma secretase do it, and the beta amyloid tends to form and deposit. Neurofibrillary tangles are neurons that are basically damaged beyond repair, deteriorating and neurodegenerative because of various factors, including the changes that we see from beta amyloid, as well as other factors such as vascular changes. And then as a result, there is generalized neurotransmitter loss throughout the body, throughout the brain, I should say, forgive me. And that's important because it therefore forms the basis of our treatment. I'll move on. So this is a tangle. That's what a tangle looks like. This is a plaque. In the middle of the plaque, you have the beta amyloid depositing. And what happens because the brain is unable to metabolize this plaque, the reaction of inflammation occurs. And the body brings in all these inflammatory cytokines and immune cells that attack this beta amyloid. But all they achieve in doing is destroying this piece of brain. And you can imagine this plaque millions and millions of times throughout the brain. So tangle, plaque, gives you this. You can see in the left picture here, a relatively normal for age brain. It's got plenty of deep white matter. The fourth ventricle is dilated. We have some atrophy. You can see some space there, you guys. The hippocampal lobe is still relatively preserved and present. This is the brain of an Alzheimer's patient. You can see the deep white matter has degenerated. There's not much of it left. As a result, the fourth ventricle has enlarged, how big it is. There's worsening atrophy in the grey matter as well. And look at the hippocampus. It's just about disappeared. So that's the brain of a person with an Alzheimer's problem. Now, why do we do it? Why do we care? Well, it's very important. We've got to do it because of safety, driving, compliance, cooking at home, not burning the house down for heaven's sakes. We need to know because we want the families to know. They want to know. They can see there's a problem. The patient themselves, they don't have insight, but the families do. And they're worried. They see mum and dad's not right, or they see their husband's not right. And you need to be able to diagnose early so you can tell them what's cooking. Once you do diagnose early, you can educate people, you can counsel people, you can talk about choices, you can talk about financial choices, management choices later on, NFR orders. Preparing them is really important because the families and the patients really appreciate knowing what the hell is going on. So therefore, they can do things like advanced planning. No wonder that it's not to mention the fact that it's their right to know, but we can also get stuck into treatments. Now, some warning signs that you may want to look for, especially in Alzheimer's patients. Memory, memory, memory. You as their doctor, you as the mother, father, brother, sister may not notice anything, but the memory affects their jobs. The memory may affect the banking executive or the doctor who's forgetting things. Performing similar tasks or familiar tasks, putting the rubbish out every Thursday like I do. They tend to forget to do that. I've got to do that. People who have secondary and tertiary languages go back to their primary language and are troubled by speaking English, but they can speak Vietnamese well or Greek well, back to the language they first learned as a young person. The disorientation can be increasingly obvious, as can their poor judgment. People making business mistakes, financial mistakes, uncharacteristic mistakes, people not bringing in the profits they're used to in the banking industry, people running a business having problems because of poor judgment in where they order and where they place their investment. Abstract thinking. I mean, I had a famous case many years ago. This is a man who developed Video Easy. He was a very, very intelligent man, and many of you won't know what Video Easy is. It was a rental agency, for the older people like myself. We never had streaming, you guys. We had video shops, okay? We used to go and get videos. We used to rent videos. And not only did they make money off us because we rented the videos, but they made money off us because we always returned the videos late. So they made a fortune off me. Anyway, he sold this Video Easy empire for a lot of money, many, many, many millions. He retired to an island in Queensland, in the Gold Coast, and I'm not joking, an island. He got bored and thought, what am I going to do with life? Well, I'll do the same thing I know what I did in Sydney. I'll make another video store. And he started that off, and the next thing his family knew was when the sheriff was knocking on the door with a piece of paper saying, you are now evicted, and this is no longer your home. And the reason this happened is poor gentleman was slowly dementing. He had problems with judgment, problems with thinking, problems with planning, problems with prioritizing. His accountant and lawyer were pulling their hair out because of issues of confidentiality, so they couldn't tell anyone, and he lost everything. So these are the sorts of cases that can occur. Losing things, keys, handbags, wallets. Where's my car? Now listen, the car one, I'll give you the benefit of the doubt because I lose my car at Westfield and I give up. But things like keys and wallets and all that, they don't happen. Their mood changes. They become moody, short-tempered, anxious, a little bit worried because they can recognize things are going wrong. And thus, there may be a change in personality and they may develop apathy. In Greek, we call it the lack of kefi, the zest for life. Let's go out, no, it's too hot. Let's go out, no, I'm too tired. Let's go out, no, it's too cold. They just lose the initiative to keep on living life. So these are early signs that you'll see. The progression of Alzheimer's dementia, it's important that you note that the x-axis here is in years. It doesn't get you in a year or two. It gets you in 6 and 7 and 8. The average survival, guys, is anywhere between 4 to 5 to 10 or 12 years, depending on how many comorbidities. And I like to use, I haven't got it there. I like to sort of use these graphs to show you how it slowly declines. I see them here early when they're mini mentals of 22 and 23 and 24. Or you guys see them here in hospital when they have mini mentals of 10 and 12 and 14, because by that stage they've fallen over, they can't function, they have a pneumonia, they're delirious, they have behavioral problems, and they're about to go into nursing homes. Remember, dementia, Alzheimer's dementia, vascular dementia is a terminal condition. It's a terminal condition. No one comes back from it, okay? You cannot reverse the changes. You can't bring them back from this disease. They will pass away. And over here, they will reach this red and blue line where they die. It may take them 9 years. Those who have CCF and COPD and terrible strokes die at 4 years or 5 years, but those unfortunates who have no significant comorbidities will go on and on and on, and they can survive 9 and 10 and 12 years, but very, very markedly reduced individuals, okay? So as far as Alzheimer's symptoms are concerned, you classify them into mild, moderate, and severe. The mild patients are the ones that I'll see. The classical problem with Alzheimer's is short-term memory loss. You tell them something, and within 10 minutes, it's forgotten. Their ability to put away new information is limited. So the wife tells him to get the breadstick, he forgets to get the breadstick. He asks again, she tells him to get the breadstick, he forgets to get the breadstick, she asks him again. And so she feels like he's putting it on. She's ready to brain him with a frying pan. She's so anxious and upset at the fact that they have memory problems. And this state, this mild state, will go 2 or 3 or 4 years, depending on their comorbidities. By that stage, we reach moderate stage, where we not only have the short-term memory, but we get more confusion, disorientation, and you may also develop problems with behavior, what we call BPSD, behavioral and psychiatric symptoms of dementia, hallucinations, delusions, things like that, agitation, wandering. Have you heard of the term sundowning? Well, that's what we're talking about. So not only do they develop behavioral problems in their moderate stage, but they're also functionally affected, okay? And function means they can't walk properly, they can't shower, they can't dress properly, they can't put their clothes on, they sit there looking at their shorts, or they come out with 4 pairs of shorts on, so they have to be supervised. By the time we get to severe dementia, where the mini mental is less than 10, and we don't know how bad it is for the poor people, these people are not walking, they can't get up, they can't do things for themselves, they can't talk, they can't swallow, they lie in bed, they have pressure sores, and they're fully dependent. And this will take years to work its way through. So they're common behavioral problems, and I want to talk about them because they're common and they're difficult to manage, guys. So this is BPSD, behavioral and psychiatric symptoms of dementia. And they're very similar to the problems you see in delirium. So remember what I said, your differential, delirium, dementia, and depression. Sometimes it's hard to tell the difference, you guys. So they can get depressed very early. 60% of Alzheimer's patients will develop some form of mood disorder or depression. They can have paranoia, psychosis. They can be very inappropriately behaved. I have a very sad case I was involved in a number of years ago. A Greek man, a very, very nice grandfather, a doyen of the Greek community. He worked in a church. He went there every Sunday and helped the priest and all that. And he developed a dementia and became hypersexual. The first phone call I get was from the police when he propositioned one of the mothers to have some sexual time with their 10-year-old daughter, which almost caused a riot in one of the Westfields. I put him on some medication. The second time I get the same call from the same station saying he did the same thing to a father for his daughter, and this almost resulted in the man being, bashed. I had to admit him and see if I can settle things down. We left him again at home, and he did the same thing a third time. And the phone call was very short. It said, "You put him away or I will." And I had to put this man at dementia-specific nursing home. It's a very sad thing to see. And you can imagine for the family, it's a horrible thing to see as far as symptoms are concerned from their loved ones. They can get verbally aggressive. They can sit there and just talk and bang and walk around and walk around and walk around. aimlessly. They're going to have difficulty in eating, mealtime behaviors, and you can imagine what happens at sleep at night. They don't settle, they don't sleep, they're in, they're out. Their likely sleep patterns include going to bed very early as the sun sets, getting up again 3 or 4 hours later, thinking it's morning, and wandering around. And therefore, you can imagine how difficult it must be for the carers. What sort of treatments can we offer them as far as the behavior? Treat any medical issues, try and get the environment sorted out, making sure they're in a safe environment, making sure the family can cope, making sure there's enough support, and then you can try and use some medications. The medications that we use are not only the cognitive enhancing agents, but the antipsychotics and the antidepressants, and we sometimes move even into treating them with benzodiazepines depending on how bad their symptoms were. So as young doctors with dementia and Alzheimer's dementia, it's important to look for them, diagnose them, and communicate with the patients, tell them, give them as much support at home with services, and then treat whatever medical problems they have. Make sure their CCF and their COPD and their diabetes is perfectly well managed. Look at driving, of course. I'm a very famous man for stopping people's licenses. You can't have them driving. Imagine what sort of problems we have in the community with people getting injured. Make sure the legal issues are addressed. So with the education, you've told them about power of attorney and guardianship. And then eventually you can talk about accommodation, because the majority of these people will require nursing home while you manage your medical therapy. Now, I want to be very quick about the medical therapy, just so you guys are aware of what's out there. First of all, you have your cholinesterase inhibitors. You guys will walk around the wards and you'll see people on Exelon, Aricept, Reminol. These are medications that they actually cross the blood-brain barrier, and what they do is they go into the brain, into the neurons, into the synapse, and they stop the breakdown of acetylcholine, which is a very, very important neurotransmitter in the brain. Remember in the pathology, I said one of the sort of pathological hallmarks is increasing neurotransmitters, where here we are. We're trying to increase acetylcholine. It really is not a reversible agent. There's no cure. It works in 60% of people. It makes them a little better as far as brightness or memory or engagement or talking. In 40% of people, it does nothing. And you've got to watch out for the side effects, my friends. Gastrointestinal problems occur in 19% of people, especially if you take tablets. The biggest worry we have as well is bradycardia causing heart block. Not common, rare, but happens. And sometimes they can do the opposite. They can make people very agitated. Other things include bronchospasm, difficulty with peeing, sleepiness, hypersomnolence, but you can deal with those. Exelon rivastigmine was so famous for its nausea and vomiting. As a specialist, I never was able to go more than I think about 4.5 milligrams. So they took it away numerous years ago and brought it back as a patch. And as a patch, it works. It's tolerated better because the gastrointestinal side effects come down from 19% to 3%. Problem is, the glue they use in the patch brings on dermatitis. It causes big round rings where the patch was of itchy skin. You can't win. So this is one group of medications that will help enhance cognition. I'll give you an example by how much. It increases their mini mental score, Falstein mini mental, which is simply a screening test out of 30 by an average of 2.1. It can increase other cognitive tests as well, but it's not fantastic as far as efficacy, but it's all we have. The next group of drugs that are available to us are the NMDA receptor antagonists, and that's just one drug. It's called Ebixa, or memantine scientifically, and that works on the glutamate receptor, helping balance calcium efflux and influx from the cell, and it tends to help people with moderate to severe disease. It doesn't do much to their screening tests like their MOCA, the Montreal assessment, or their RUDAS, with a Roland Universal Diagnostic Assessment Score or their mini-mental. But we do know from feedback from the carers when we do carer tests, these patients are a little bit easier to manage, more engaged, more talkative, easier to deal with as far as their ADLs are concerned. You can use both this one, Evixa, and the cholinesterase inhibitors together. We have evidence they work better together than alone, and they're much more affordable nowadays. When I first started practicing, you'd have to pay $200 for one of these and $280 for one of these, which would be a total of close to $500 a month. That's expensive, and people couldn't afford it. All right, listen, it's now 7:30. I'll be very quick with the last 5 or 10 minutes. I just want to talk briefly about vascular dementia. Vascular dementia is a dementia that's associated with an interruption of blood flow to the brain, causing damage to the brain. It could be one big stroke, it could be two medium strokes, it could be multiple small strokes, it could be hemorrhaging, it could be multiple small vessel disease, white matter disease, it could be encephalopathy from vasculitis, and other rare conditions, but anything that leads to the vascular supply being interrupted and causing damage, okay? Now, the type of dementia we get, whether it be deep white matter or stroke in vascular, is a little bit different. You still get the memory loss, you still get short-term memory loss, you still get confusion, but it's a little bit different as far as their presentation is concerned. They're slower, they think slower, they respond slower, they process slower. They may have speech difficulties, word finding difficulties, being able to name objects, being able to get the conversation going. They get inhibited and they have problems in getting the word out. Sometimes the word comes out easily, and sometimes they're trying to say it, but they just can't get it out. Their speech is worse when they're troubled, stressed, anxious, unwell, and haven't slept. It's better when they're relaxed, rested, not sick, and not in stressful situations, okay? So processing speed is reduced. Their judgment and problem-solving skills are worse, okay? Behavioral problems can be seen much earlier. In Alzheimer's dementia, you'll see BPSD a bit later, moderate disease. Remember I showed you that graph? But sometimes in vascular dementia, the first presentation you get in some patients will be psychosis, will be with delusional thought disorders. The man who thinks his wife is having an affair with two neighbors. The woman who came to me and said there's red spiders all over the room, get him out of there. Her mini mental 30 out of 30. Her mocker was 28 out of 30. She told me everything that happened that day. She told me what she shot for. She told me what her plans were for next week. But she asked me to kindly and politely, please get rid of the spiders. They're bothering me. So they come purely with behavioral problems, okay? And we see a lot more mood disturbances, both emotional lability and depression. So it's a different type of dementia. And they're also associated with functional problems, especially a vascular gait. How many of you have seen the vascular dementia patient come into the hospital, come into the ward, shuffling in a stooped posture, moving slowly, bradykinetic, having the marcha petit pas, the march of small steps, stiff and slow, difficulty standing, difficulty sitting. It's called Parkinsonism, most commonly associated with small vessel cerebrovascular disease. And this is why I say to you in the beginning of the talk that mixed dementia is making a very quick run up the outside of the lane, because you get patients with both Alzheimer's problems. So the patient's family will tell you, doctor, hello, this man, I tell him one thing and 30 seconds later the memory's gone. Is he having me on? I'm going to get into the cricket bat. And then at the same time, the daughter will say, but he's so slow, doctor. He used to be so quick. He used to be so sharp. And look how he moves. these people have mixed disease. Now, before I go to Lewy body, the treatment of these vascular dementia patients are fairly similar. They respond to cholinesterase inhibitors in 60% of the cases. But the difference is you're going to have to get a little bit more involved in managing their behavior. You may have to get involved earlier on in managing depression, and you may have to get a little bit involved in managing behavioral issues such as psychosis or hallucinations by using your antipsychotics earlier together with the anti-dementia pills, okay? Now, the last type of dementia I want to briefly speak about, and then I'll leave you, I'm very conscious of time, is Lewy body dementia. It's a dementia, a neurodegenerative condition characterized by the presence of these physiological sort of Lewy bodies in the brain. And I'll have to ask you to look the exact histopathological picture because I haven't got one here. But this is an interesting dementia because we're seeing more and more of it now that we're more and more aware of it. It really has 3 or 4 cardinal features that we see all the time. One, it's very, very progressively, the dementia is very progressive, so the cognitive impairment is very, very notable, profound, and quick. They're usually dead in 3 to 5 years. 2, they have terrible periods of delirium, confusion. They will turn up to emergency screaming and kicking and bouncing off the walls. It's a terrible delirium. It's a terrible state of confusion with agitation, etc. 3, they get Parkinsonized. They develop that gait that I talked about with the stiffness, the bradykinesia, the shuffling, and the slow movement. 4, they have something called REM sleep disorder. REM sleep disorder is, when we go to sleep, we go through the usual levels of sleep, and by the time we hit REM sleep, we're paralyzed. So just in case, some of us who like to have dreams about jumping out of a plane with a parachute, don't jump out of bed. Well, guess what? These poor guys don't have that paralysis, and they tend to live out their dreams. So if they're in a boxing match, they have a boxing match with their partner in bed. If they're jumping out of a plane, they jump off the bed. They're quite agitated and jumping around at night. And these patients present often as a delirium. These patients are treated by the emergency staff in emergency, and what they give them is big doses of antipsychotics like haloperidol. What did I just say to you before? Treating delirium, haloperidol, and a benzo. The problem is if you give these guys too much haloperidol, they're very, very sensitive to neuroleptics, and they develop neuroleptic malignant syndrome where they become stiff like a board. Blood pressure goes up, they become febrile, they become profusely sweaty, they drop their blood pressure, and you can't reverse it. It's ICU, fluid, supportive care until they get over it, and it takes me weeks to get them moving again because of the severe extrapyramidal rigidity that develop. This disease is quite responsive to cholinesterase inhibitors, by the way. 50% of cases respond. Interestingly, the government hasn't approved cholinesterase inhibitors for this. The last thing I want to mention, sometimes you have to use antipsychotics in these patients, and because of their extrapyramidal sensitivity, you probably should use something called Seroquel, quetiapine. It's an antipsychotic that's quite reasonable. It has less extrapyramidal effects, more sedative effects, and mild to moderate antipsychotic effects. To be perfectly honest with you, as a medical student, as you come along the medical wards, you'll see quetiapine or Seroquel, you'll see olanzapine, you'll see risperidone and haloperidol. Haloperidol is the only antipsychotic. It's an old antipsychotic that you can give parenterally. It has very strong extrapyramidal features. Risperidone is approved by the government, and we use it commonly. Again, the side effects of these antipsychotics, extrapyramidal features, Parkinsonism, increasing metabolic effects, it increases appetite, makes them eat, which is a good thing in our elderly folk. and anywhere between 1.9 to 3.1% chance of sudden death from cerebrovascular and cardiovascular death. Unexpected, bang, down goes the person. So it's important when you use these drugs that you talk to the families, you warn them. By the time I get to having to use the drugs, I've got no choice. I've got to use them. So away we go. Remember, bringing the family on board and getting their permission is very important. Listen, I don't want to say anymore. It's now 20 to 8. Most of you, I suspect, have fallen asleep or are hungry to have some dinner. I just wanted to touch on two important parts of aged care medicine, of general medicine that you will see on the wards commonly. And I just want to make sure you're at least introduced to the topics and know and are familiar with some of the concepts and some of the issues. It's a huge area. It needs a lot of reading, not only looking at the causes, and if you're very interested in the actual physiology involved and histopathology involved, but more so with the pharmacology involved in treating these patients and the symptoms you come across. Having said that, I bid you all a very, very good night. Thank you for listening. Our next talk, when it's my turn, I don't know, I've got to ask Professor Garanham, we'll be dealing with COPD in the elderly especially. And until then, I bid you all good night.
Sorry, go.
Thank you, Dr. Dedousis. Is it okay if any of the students want to ask a couple of questions?
Absolutely, go ahead.
Great, thank you. Go for it, Mikey.
Thank you. Hello, and thanks for the lovely talk. Just wanted to ask about the symptoms, the dementia symptoms, if they're sort of related to their pre-diagnosis personality. So someone that's
a very good question. Now, I haven't been able to give you the whole talk. It would have taken me 2.5 hours, but we know that people who are, pre-morbidly very anxious, upset, depressives, will be much worse once the dementia sets in. They'll become more frontal, and their ability to control and deal with those, say, psychological symptoms will be much, much reduced, and therefore their symptoms will be more prominent. We know people who have already diagnoses of schizophrenia, depression, schizoaffective disorder, bipolar disorder will do much worse as far as their dementia is concerned. Their progression will be faster. They have an increased rate of plaque and tangle development, and they will be much more difficult to handle, and they do go much faster. So yes, the man who was a nasty man many years ago, who's self-centered, a difficult man, a man who beat his children and beat his wife, will often, once become demented, be quite a difficult case and a bit of a nightmare of a case, because many of these behaviours, whether they're learnt or innate, will be very obvious and difficult to manage.
Okay.
It's not often you see a man who was like that become demented and turn into a little lamb, unfortunately. Next question.
Thank you.
Anyone?
It'll be interesting to have a talk on, because I work a fair bit in older persons' mental health.
Yes.
And
what's your perspective?
It's just so hard. It's so hard. People that have different diagnoses of dementia, and then they have mental illness, or they had mental illness and then they get dementia. They get mixed dementia, and then they're older. So obviously they have a lot of comorbidities. Then they might have some trauma in their lives as well. It just gets really hard to manage those people in the community and even in aged care facilities. And then it just sort of seems that it gets to a point where nothing works. They've done sort of 15 ECTs and then it still doesn't work. And yeah, it's quite hard.
You'll see a lot of that. You'll see people who have their primary underlying diagnoses of schizo or depression or whatever they have. Now, you've got to remember, first of all, and primarily these people, for instance, schizophrenics, you know, they have an increased rate of vascular change in the brain, strokes and comorbidities that are horrible. So they have these behaviors that go on and off. Then the neurodegeneration appears with the dementia part, whether it be vascular, mixed, or Alzheimer's. They mix. The behaviors become very difficult. You use ECT becomes less helpful in those pictures, apart from depression. ECT is great in the elderly depression, but in those who are quite demented and have problems with neurodegeneration and psychosis, it's difficult to treat. They become very, very symptomatic, and then they're placed. Now, we know that if we place a person and put them in the right place, in a dementia-specific ward with trained staff, 50 to 60% of them will settle, largely by non-pharmacological means of looking after their needs and responding to them in a trained way. But you still will have a small amount of group that will require quite heavy medication use. And unfortunately, that's why we have places like in our area of the world, it's called Garawara, okay? And this is where they have terrible sort of behavioral problems, many with underlying chronic psychiatric issues. And it's very challenging, and the poor families, they suffer.
And then you add sort of history of substance abuse
But
that as well, which is...
Substance abuse in our elderly is interesting. You know, when you say substance abuse, you think heroin, ice, cocaine. It's not that. It's benzos, painkillers, okay? Sleeping tablets of various sorts that they're all hooked on. Painkillers especially, and they come along and you try and wean them, you try and take them off, and it's very hard. It promotes delirium even more. So that's quite challenging. That's the sort of substance abuse I see. And we're compliant in that, by the way, as doctors. We put them on it. They come in on 30 years of Seropax or 25 years of temazepam or whatever, and it's too late. It's just not worth stopping the medication. You just don't do it. You just keep it going. Don't increase the dose. Minimize it if you can. Bring it down. But the majority of the minute you take them off they go. Any other questions from anyone else? I don't think there's anyone else left.
If we have time, can I just ask a last question?
Of course.
What is your view on cannabis oil?
Excellent thought. So the role of
It's
cannabis,
quite common now. It's coming a lot more.
the role of cannabis, as far as I'm concerned, there are three main uses of cannabis in our medical community at the moment. First of all, we use the cannabis in the very, very unfortunate poor little babies with treatment-resistant seizure activity, and it does work. And I'll leave that for the pediatricians to talk about it, and I'll keep out of that. Two, cannabis has a role in the management of pain. Okay, it does work. There is an increasing cohort of patients that we have that we manage with cannabis. We're all getting on board now, getting qualified and trying to use it. And it works in about, I would say, anecdotally 60% of people, giving them some relief and also allowing us to back off on our narcotic load with his elderly. And then there's the role of cannabis in managing behavioral disorders, BPSD, that I said. So with behavioral disorders, we have the cholinesterase inhibitors. We have the antipsychotics, which we talked about. We have second and third line agents like mood stabilizers, Epilim. Some of the psychiatrists love Tegrenol. We avoid, but we have to use the benzos. And then into the mix comes cannabis. Now, unfortunately, we don't find cannabis very helpful. We did use quite a bit of it in our behavioural unit down in the southern area of Sydney, and the majority of patients did not respond well. It really didn't add much to the mix. Having said that, though, I have anecdotal evidence. I have patients, I have families, who went outside the system, sourced their own cannabis from America or the States, and there are occasional patients who have responded by settling. So my advice as far as cannabis is concerned is if you're desperate and need to use it, give it a go. There is a role, though, I'm not so sure it's an effective role. And it's interesting, in this part of Sydney, there's 2 or 3 professors that use it. Professor Peter Smurley that thinks it's a joke and it's a waste of time. Professor Gonski is using it a lot more for pain, but very minimal for behaviour. And certainly myself, I'm starting to use it a lot more for pain, but not for behaviour, because it hasn't worked. I must have had at least 15 patients on it, and I don't think there's one of them that did really well. There is no role for cannabis in the cognitive aspect. It's simply on whether we're managing severe behaviours that require control in dementia-specific environments. Thank you for asking that question. I'm sorry, I can't fit it all in. Any other questions? You and I should have a conversation. Let's continue.
No, it's a very interesting topic.
Oh, I love the topic. It's unfortunately, guys, it's a topic of the future. You can't get away with it. As medical students, you will have to become familiar and comfortable. It's amazing how many of my colleagues literally cannot stand the issue of dementia, dealing with dementia patients. It makes them feel uncomfortable. They feel uncertain. They feel unconfident in dealing with it, and they automatically ask for the geriatric people to get involved. I just want you guys to at least be familiar and not run from it, but rather embrace the problem and try and deal with it one by one by one. Any other questions?
It's not really a question. I'm just really interested because I've worked, I think, like Marky, in with the elderly and specifically with dementia residents in a nursing home, and it is a nightmare for the nurses. And where I worked, it wasn't a specific, it was a mixed residential care setting. And the big problem, one of the problems was the falls risk related to the prescribed antipsychotics, for example. And so there was a worry about whether these prescriptions were actually helping or not with the behaviors, or now they're falling over, so we have to change the dose again. But so then it was just a really difficult thing to manage, and the medical management didn't look any easier than the nursing management. And I wonder if you could comment on the falls risk. I actually did my research project on this because it was such a...
What were you doing in the nursing home? Were you a doctor in the nursing home?
I was a nurse, yeah.
Yeah. So listen, I'll take it's an excellent question, and thank you for asking it and allowing me the time to talk about it. I obviously work in nursing homes. I've done so for 25 years as a specialist involved. I think the Royal Commission that came out in the last 12 months was fantastic in bringing to light the issues we have with psychopharmacology and its use in the elderly, and bringing to the forefront the side effects and the problems we face. And I think the overuse of that medication group, especially the antipsychotics. And I think it's been thus successful in having us as specialists relook at our approaches. And I must say, all of us, there's not a single person I can have gone through our practice and we've minimized our load because of the problems with side effects, because of the extrapyramidal features, because of the increased risk of death, because of the increased risk of falls. The antipsychotics cause falls, right? Extrapyramidal features. The benzos, they're well recognized for causing falls. What we've managed to achieve is to stop as much, I think a hell of a lot of benzo, which is great. We've managed to replace the benzo by non-pharmacological management, trained people, which is fantastic. We've managed to decrease the amount of antipsychotic use tremendously. However, there has been a little bit of a perverse background increase in use in mood stabilizers, such as Epilim or Tegretol, which I don't mind as much. But again, some of their biggest side effects, as you would know, when you give Epilim or when you give them falls, right? They get ataxia, right? So there's been a bit of a rebound in their use by specialists. Oh, I can't use risperidone, so I'll use Epilim. And in the end, they still fall over. But it
They
isn't
fall
too,
over and then they got, yeah.
they
And
still fall
falls
over.
are just, yeah. Such a,
Unfortunately, there is a small group of patients that you cannot take off. And I don't care which Royal Commissioner talks to me or says anything to me. I want them to come in and be the nurse on that night
do
shift.
the night shift, and then you'll see.
You'll see. So I'm all for reassessing our use. I understand the falls risks. They're huge. I understand the risks of them sleeping all day, aspirating because they're half narcotized, falling over and really losing weight. And it's not really a good life, is it? But there are a small group. I must stand by. I'm so sorry that we need to use these drugs.
Yeah, no, I've
That
seen.
group is small, and we'll never get them off because we need them for their safety and their quality of life, let alone ours. But I take on board, as a nurse, you've probably been through a hell of a lot trying to deal with these patients.
It is just because you were talking about the restraints, and there are no restraints.
They're gone.
And so it puts the nursing staff at risk because, when you have tall, angry, uncomfortable, not just uncomfortable, just completely bewildered. And I think you're talking about the 3Ds. The person I'm thinking of probably had the 3Ds all at once, with this classic sleep reverse cycle. So it is, and what you were mentioning about working with the nursing team is like spot on, because you need each other in the team.
Absolutely.
To work through how to give the best care, and it really is about safety of everybody. Staff, families, and families obviously really high on the list of they're not there and they're worried about what's going on. So it's
we've got to support each other. Remember, I spend 5 minutes with the patient, and you spend 9 hours.
All night sometimes.
So who knows the patient better, me or you? You. Okay. So when we do rounds like this, I mean, you must have noticed this now in the hospital if you've been there. But when we round and we work in hospitals, we're with our nursing staff. Sister, I want a round. I call everyone sister out of respect, but I want a round. I want you with me. I want to know what the bowels are doing. Do you think I know what the bowels are doing? Do you think I know if he's peed? Do you think I know he's eaten? Do you think I know what his behaviour's like last night? No. So the teamwork is critical. And in my medical terms, my guys learn that teamwork is essential. But I get what you're saying. And I think that the Royal Commission, though helpful, shouldn't be allowed to go all the way too far to one side and get rid of all the drugs, because it's counterproductive.
Yeah, because you need the chemical restraint just so that they can go to sleep, because you haven't got the staff to sit with them. There's just not enough.
We don't have one.
No, not at all.
But I can't agree with the restraints. The restraints, when I was a kid, when I was an intern, I'd walk in the door.
No, obviously we don't.
And there'd be 10 patients spread eagle. And if you didn't have restraints, you'd use gauze. You'd use gauze and run up.
No, I mean we're definitely in a better place in that sense. But with not enough staff and time to do the non-pharmacological therapies. I mean, just sitting with someone, and I've often remembered encouraging staff to, imagine that the lady has a wound and you need to sit there with her. You need that time. You need 20 minutes to do something else. Well, use that time to sit next to her and just be there. And often, that time's not there, or that time's not thought to be needing to be dedicated. And they're just moving around the unit, and it does work, the non-pharmacological care, but you have to.
We train our nurses enough for this at the moment. What do you think?
Oh, definitely not in terms of who gets that training. I mean, nurses are always asking for more training, and will go for that. I think the place where I was working, because it was a mixed unit, that was difficult. It wasn't a dedicated dementia unit, which I think must, and I've, you know, there was one elsewhere in the state, one or two or more. So I think that was a challenge. And like you say, that is important. The expertise in the care team is key. And you can turn things around without drugs.
Even though as an intern, when you're an intern, you'll go to the hospital, you'll realise on overtime, the medical ward, the aged care ward won't call you as much because they're trying their processes. They've been trained, they're sitting, they're talking, they're de-pervasing, they're DR, you know, they're trying to use their training to help. With a surgical ward, they're ringing you as the intern and saying, "Doctor, I want you here now. Come and fix the problem." She's climbing through the door.
Yeah, it's just
not enough training in our nursing staff.
Yeah, I think so. Anyway, this is wonderful. It's good to hear about your perspectives as a professional geriatrician. That's who you are. Yeah.
That's one of the roles I have in it.
Yes. Sorry, I didn't really. I'm just like zooming in because I'm sure it'll be good. And I don't exactly know who you are, but it's been brilliant. Sorry.
Come and do medicine with me. Come over to St. George.
Might do that. Yeah, you might regret saying that. Yeah.
But how fun is dementia though?
But dementia is great fun. I enjoy dementia.
How fun is it? I love it.
I love dementia. It's my favorite area of practice because, guys, it's part of geriatrics. It's a wonderful job. There's no other job in medicine, I feel, where you insert yourself into these family spheres and you're part of the gang. You're part of their friendship circle. You're part of their family. You sometimes cry with them. You sometimes laugh with them, and you're with them all the way. So you get really involved, and you see the poor patients at their most basic level, and you help them out. It's a group sport, and it's something that I enjoy. But you've got to be confident in talking to people, communicating with people, and being with people. And if you're unconfident, if you feel that you need the safety and remoteness of a pathology screen or a radiology screen or the ICU screen, well, you know, it's not for everyone. And that's where you as students need you guys. So the reason I love working with the OUM students versus the University of New South Wales students, which are my other students, all those guys are 17 and 18-year-olds, right? And 19-year-olds. And they're at the beginning of their careers. They haven't had much experience. They're very intelligent people. And they're different compared to you guys. Because I've just spoken to a nurse. I've just spoken to a healthcare psychiatric care worker. Nabil used to be a respiratory scientist. My current medical student at St. George here, if I remember correctly, was a drug rep / scientist and pharmacist. In the past, I've had, Lene Jones, my physiotherapist. So you guys have enjoyed life. You've experienced life. You're more mature in your appreciation, your perspective, in your approach. And I think you make the best doctors because you hit the ground running. It's just you have to work really hard.
I hope so. I want to be a geriatrician when I grow up.
When I grow up, yeah.
When you grow up, unfortunately, you will have to do the physician's exam. And that's going to be a challenge for you. It's not impossible. It's not insurmountable. It just means a lot more hard work. And again, because of the way you've come through the system and the type of training you're doing now, I think you're very well placed to be able to take on the rigors, responsibilities, and needs of preparing for the physician's exam. And because of your maturity and experience in life, I feel, looking at you guys, that you would do really well. I think you would progress quickly and do well in that sort of career. It's just, can you guys afford the time? I don't know. That's a personal decision.
We're addicted though.
I'm so sorry?
It's an addiction. It's an addiction, isn't it?
Well, yeah, I'm very happy to speak to any of you offline if you want about career pathways, how to chase it, what to do. The wonderful thing about medicine is we have so many niches in medicine. You can pick a career and you can change and do what you want. remember, what I say to you as students is make sure you pick something you love, because it's the next 35 years. You've got to get up in the morning, put your shoes on, and go to work with a smile on your face. And it's very hard to do if you don't like it. Don't chase money. Forget money. It's not about money. It's about enjoying your work and contributing in a compassionate and kind way to the community. So, you know, how much money can you have and how much money can you take with you? So what? You know, but be happy. Make sure that you enjoy your work, because it gets very tedious if you don't.
That's true for a lot of careers, though, isn't it? Yeah. The
And you
job
can tell those
satisfaction,
people.
yeah, is, yeah, you got to love your job, or most of it. There's always bits that are unpleasant or, yeah, just boring. But
I mean, I can tell you two have moved on from nursing into medicine because you two want to contribute more. You want to be able to make more of an effect, to be able to impact people's lives in a more positive manner than you're able to at the moment. And I admire that. I tip my hat to you, because it's the right reason to do with medicine. It's the right reason.
And then like the curiosity, I think, really gets me. Like I just want to, it's like I just want to, if I could actually hear what the doctors, their thought process, like what are they thinking? What are they weighing up? And
you probably don't want to know what they're
going
on. Yeah.
To come to
that's
a conclusion,
right.
to come to
that's right. Yeah, because you have to. Exactly. Yeah.
You guys have got to come and work with me at Karina or St. George. I think you'd enjoy it.
Sounds good.
Could do.
In
Could
about
do
10 to 15 years. See you then.
Dr. Dedousis, thank you so much for this wonderful session. It was really, really great, and great to have this time as well to chat.
Love a bit of chat time.
You can all contact me.
You know me, Nabil.
If you need any questions, you can contact me anytime. I'm very happy to walk you through the physician's career pathway, getting into the hospitals, what you need to look for, etc., and prepare. Because remember, you have a bit of a different pathway to the rest of the students I teach. So you've got to be a little bit more prepared and ready. It's not insurmountable. It's just, as I said, it involves a lot more work. But it's going to be very rewarding for all of you. And I want to wish you all the very best of luck. I'll see you in our next session.
Great.
Thank you so much, Dr. Dedousis.
Whatever you're talking about, I'll be there. Thanks, guys.
Thank you.
Nabil, I don't know how to turn it off, mate. Sorry, dude. Oh my God, sorry.